said, my name's Lisa Bell, and I'm a physical therapist with 30 years of experience in various settings. I started my career primarily working with a neuro population that is treating strokes and spinal cord injury, then transitioned into orthopedic work, treating things like back pain, joint replacements, and such. And I've always had a special interest in balance disorders and fall risk reduction. So when I started doing work with vestibular disorders, it brought all my interests together. So I have some specialized training from Emory University and another certification training that is from another group that has a combination of staff from University of Texas. And I feel that this work represents what is a true specialized skill of a physical therapist as a movement specialist, helping people regain the ability to move. Today, I'll be reviewing some anatomy of the vestibular system, some common disorders, and also how you would go forth with seeking help or care if you think you have a vestibular disorder. Okay? So let's start with a few definitions. Dizziness is a sensation of lightheadedness, faintness, or unsteadiness. Vertigo might be thought of as a perception of spinning, either yourself spinning or the environment. And disequilibrium might be a description for a loss of equilibrium, which can feel like spatial disorientation or imbalance. So really, there's no wrong way to describe how you're feeling. These are just some examples of some, say, medical terminology. But I've heard a variety of descriptions from my patients. Things like, I have a swimmy head. I feel like I'm floating. I feel like I'm rocking. I feel like I'm off balance, lightheaded, or on a boat, and many more descriptions. When you're seeing your healthcare provider, it's important to use your own words to describe how you're feeling. So as a physical therapist, when I'm interviewing someone, their own words gives me a sense of the source of their problem. So it's better just to describe it yourself. And it is difficult, but it's better to do that rather than come in and say, well, I was told I have BPPV. Don't diagnose yourself. And hopefully, I'll ask about your medical history, but a lot of people come in with a diagnosis, but when we do the evaluation, it turns out to be something a little bit different or a combination of things. So your own story is the best way for your practitioner to find out what's happening and how to help you. So balance and movement is a feedback loop between sensory input, which is what we feel, and motor output, which is using your muscles and your joints. The feedback loop that helps us keep our balance relies on three major sources of sensory input: the visual system, the somatosensory system, and then the vestibular system. So within the vestibular system, that consists of the peripheral vestibular system, which is the inner ear. So that is like your inner gyroscope. It's inside your ear. You can't be seen from the outside. You can't touch it. It's about the size of a fingernail or a dime. It's very small. Some of the structures in that are your cochlea, semicircular canals, otoliths, such as the saccule and utricle, and the vestibular nerve, also known as cranial nerve 7. This is right next to the facial nerve and the auditory nerve. The central part of the vestibular system is the brain, and there are nuclei within it. And most of those connections are in a part of the brain called the cerebellum, and the cerebral cortex, and the brainstem. So I'm going to pull up a little diagram of this. Let me see if I can get this. Let's see here. I'm going to go to here, to here. Let's see. Whoops. Okay. So here is a human ear diagram Again, showing the ear canal. And so inside the eardrum, those are the sensory organs for hearing. And then the kind of bluish, purplish structure is the inner ear with the cochlea, which looks like a snail. 3 semicircular canals, those are filled with fluid. And as you move your head in different directions, that fluid moves through the canal, stimulating the hair cells. That tells us what direction we're moving in space. It gives our brain angular velocity. And then it shows you the vestibular nerve and the auditory nerve. And the other sensors I mentioned detect acceleration, deceleration. They detect if we're going up or down. So these are the things you're using, say, if you're underwater and you can't tell where the ground is, and if you can't see, if your eyes are closed. Or, if you're in an elevator, you can't tell that you're moving because the whole box moves with you, but you can feel that. You should be able to feel that, okay? Okay. So when you have a physical therapy evaluation, you will undergo tests to isolate each of these sensory systems, which can help determine what's working and what's not working. This will aid in a diagnosis and will guide the therapist to prescribe a personalized exercise program. So we're going to do a mini personalized seated version of this testing. If you can and you feel comfortable, go ahead and scoot to the edge of your seat so you're not touching the back of the chair. Now, again, if you feel comfortable, you're going to lift your feet off the ground. Then you're going to close your eyes for 30 seconds, which I will time. Ready? If you want to, if you can, and close your eyes. It may be a little challenge for your abdominals. So the eyes are closed. We have a little bit of, do a little meditation while you're here. See if you can feel if you're wobbling around, if you feel your weight shift to one hip or another, if you feel yourself wobbling forward or backwards. This is your somatosensory system giving you the pressure sense. But we've taken away your visual system, so you also have your vestibular system helping you. There we go. And now open your eyes. As soon as you open your eyes, you should notice you feel a little more stable. Put your feet on the ground. With your feet touching the ground, you have more somatosensory input. Feels a lot more stable, right? And if you try something like this at home, if you want to, do it in a safe place where you have space around you, and you could put your feet close together. That narrows your base of support, makes it a little more challenging. And as soon as you close your eyes, you may notice some sway. So it's normal to have some sway. None of us stands completely still. And with your eyes closed, your brain is having to use the vestibular system and the somatosensory system, and this way you can train that. So that is a test and a treatment that we do for people. So if you tried this while sitting on a soft surface or a boat that gives as you sway, you would have less somatosensory input. Then you would be depending most on your vestibular system. So let's talk with focus on disorders that affect the vestibular system, especially the peripheral system. In the upcoming slides, I will go through these common vestibular disorders. Keep in mind that this is a short list. There are many other types of vestibular disorders which exist, and more that are being delineated with ongoing research. Let's start with BPPV, which is probably one of the most commonly known vestibular disorders, and some of you may have been told that you have this. So what do all these letters stand for? The B stands for benign, meaning it's not life-threatening, although it can feel pretty horrible when you have it. Paroxysmal means that it comes on suddenly, so you may feel just fine, and all of a sudden you have this feeling of spinning. Positional means that it's related to head position or movement. So oftentimes someone will say, I turned over in bed onto my left ear and all of a sudden I started spinning and the room started spinning. Or I bent my head downward and I felt that feeling. And so vertigo is this false sense of spinning. So BPPV affects those semicircular canals that I mentioned. Let's see. BPPV occurs when small calcium carbonate crystals, or they're sometimes called rocks, break loose and fall into the semicircular canals. So they're not supposed to be in the semicircular canals. They're supposed to be in a different spot. So these rocks will create a sensation of spinning as they move through the canal and stimulate those hair cells. So what happens is if I turn my head this way, the fluid moves in the canals, and that tells me my head is going to the left. But then when I stop, I should realize that I'm still. Now if I stop here and those crystals start moving, they start moving and they will stimulate those hair cells, and now I'm going to go, I feel like I'm spinning. So I'm actually not moving, but I feel like I'm spinning around because those rocks are stimulating those hair cells. The hallmark description is the sensation of spinning that occurs with head motion. It lasts for seconds to minutes, usually less than a minute. So what is distinct with a lot of these disorders is how long it lasts. With BPPV, if you move your head and it spins, if you stay still, it should go away within a minute. Now, sometimes it feels pretty horrible, so a lot of people will change position and then it will go away. But if you actually stayed in that position, it should subside. The most common type of BPPV can effectively be treated with a repositioning maneuver known as the Epley's maneuver. And research shows this to be 80 to 90% effective with one procedure. Sometimes that means a few times doing the procedure, but sometimes one visit. And as a physical therapist treating vertigo or BPPV, we love to hear stories that suggest that someone has BPPV, because it's one of the disorders that I can actually say to somebody, I can fix you, hopefully. And there's not a lot I can say that to somebody about. I can fix you within one visit possibly, and that has happened. So that's why I like to mention it, because it's not life-threatening, and eventually, oftentimes the BPPV itself does resolve. Your inner ear actually dissolves those crystals, but it takes time. The problem becomes when during that time you change the way you move and you're afraid to move, it puts you at higher risk of falls, and it also can lead to other sensory disorders. So if you can get it addressed quickly, then that's helpful. So I'm going to show you a video that demonstrates the Epley's maneuver. Okay. So normally with head movement, the fluid moves. Sometimes there's that crystal that this gets displaced. The fluid movement occurs due to the crystal rather than the head movement. It causes the brain to think that movement is occurring even though you're still. So you put the head in various positions. And as you move the head through these positions, it may present with some eye twitching called nystagmus. So if you have this at home, if you have someone around who has a phone or a camera, say, come on over here quick and videotape my eyes. I literally diagnosed this in my sister from across the country when I was in Georgia, and I had her keep the phone up to her eyes and helped her treat it over the phone. And so if you have someone take a video and they can bring that into the therapist, that would be helpful. So it's repositioning. And it's kind of like those games with those little balls that go through a maze, and you have to turn it and turn it and turn it just the right way to move the ball. If you don't complete those turns, that ball might fall off or go back. So that is the problem, is if you don't move the crystal through the canal and out, then it stays there. And then each time you go to move in a certain position, you get that sensation again. And it can be pretty horrible feeling. It can make you nauseous. It can make you throw up. Now, just to know, there are different types of BPPV. So there's some that can affect different canals, and there's some that can be in different structures. So the Epley maneuver is only one maneuver. And so say if you've done this at home and somebody said, no, just do this Epley maneuver, and you've tried it and you say, it doesn't work. Sometimes you have a different form. So that's when you need to see a vestibular therapist. So the BPPV is diagnosed in the clinic doing the Dix-Hallpike positional test, which is best seen with the use of infrared goggles, because what happens is that eye movement that it showed, that goes away after a few days because your brain actually learns to stop the eyes from moving. That helps you keep better balance. So you may not see it if you've had it for a few days, but we put these goggles on your eyes that have small cameras in them, and you won't be able to see anything, but the cameras will record your eye movement. And when I look at the eye movement, then that can tell me if you have BPPV and what type of BPPV you have, and that will let me know what type of maneuver to treat you with. Does anyone have any questions? Yeah, I figured.
What is the connection with the eye movement? What makes that happen in conjunction with the little thing?
So that is where, say, if I'm moving my head one way or another, if I can focus on one object, then that can help me know where I am spatially. So I'm using my vision. And so when when my head is moving, it's normal for my eyes to sort of move and find a target to hold on to, but then as I move, it has to kind of move again and catch up and catch up. So you'll have this movement. So there's some movement, some nystagmus, that's that jerky eye movement, that is normal. And you can see that if you ride a train or if you're in a car, or actually if you ride a train, next time you do that, and have somebody look out the window. While they're looking, they're going to try to fixate. Their eyes are going to try to fixate on the moving environment, and you'll see the eyes go boop, boop. So there's a quick, fast phase and a slow phase. So there's some amount of nystagmus that is normal. So this is all the interaction between the visual system and the vestibular system to help us orient ourselves. Yeah. Yeah.
What causes the calcium carbonate crystals to form?
Yeah, that's a good question. So they're existing in the inner ear naturally. They actually usually sit sort of on a little pile in a certain part of the inner ear because our sensory system is oriented to gravity. So they help some part of it be a little heavier so that as I move relative to the ground, I know where I am in space according to gravity. So what happens is just that they can shed or fall off. And oftentimes that may happen if you have some other disorder that interrupts the health of the inner ear. So sometimes that can be hypertension, blood pressure problems, because it is a fluid-filled system. Sometimes you might have other disorders, which I'm going to mention, that happen that can affect the nerve and cause an infection in the inner ear. So those are a few things that can cause it to come off and float around. Yeah.
If you get your high blood pressure under control, will that fix those?
So it won't fix the BPPV when it's happening, but what that does is lower your risk of having BPPV. Yeah, good question. Great questions. Anything else? Yeah.
So if a doctor looks at your ears, can they see if there's an infection in the inner ear?
No, not necessarily. Yeah. So again, the inner ear is inside.
Right.
They can't see it from the outside. So it's more when you have an infection of the inner ear, the question is whether it affects different parts of the inner ear. And I'm going to actually go over that later because there's two types of that. Yeah. Okay. Anything else?
But you would go to an ENT to find that out?
Yes, an ENT is the best person. If you are having problems related to sort of ear fullness or pain, along with dizziness and imbalance, if you can see an ENT who has a specialty training with vestibular treatment and diagnosis. That's important because not all ENTs do. So you can ask that. There is an advanced specialization within ENT called a neuro-otologist. And the neuro-otologists in the area would be based at UCSF or Stanford. Yeah.
I'm not hearing what the, is it?
ENT, which can stand for ear, nose, and throat doctor, or sometimes it's called otolaryngologist. Does that sound right?
Thank you.
Yeah. Yeah. Okay. All right. So speaking of ear infections, vestibular labyrinthitis and neuritis, are two types of inner ear infections. They're usually viral, so they're not the same as the middle ear bacterial viral infections. The symptoms are typically a sudden onset of mild to severe dizziness, nausea, vomiting, unsteadiness that can last from hours to days or weeks. So you see that this one lasts longer than a minute. So if you have this going on and someone tells me it lasted for hours or days, I'm thinking that is more than just BPPV. It can be included a loss of hearing and tinnitus or tinnitus, which is a ringing in the ears. And that distinguishes labyrinthitis from neuritis. So again, your symptoms will let your physician know what is happening. The diagnosis is done through clinical assessment. So you asked how. So it's your presentation. It's you coming in and giving it your history and a process of elimination. Again, eliminating, no, it's not this, it's not this. Then, if necessary, they can order a test called a VNG test, which stands for video nystagmography. That's a specialized inner ear test. And let's see, there is an audiology office in Santa Rosa, I know, that conducts VNG testing. And then other than that, I think it would be going to UCSF or Stanford. So the treatment includes vestibular therapy, which can help speed recovery and promote full recovery. Also, medications can be given to relieve symptoms and to help infection. If treated promptly, you can have a full recovery. So what we say is, if you have this happen, 95% of the time, you shouldn't really have another one again. So it's not something that you say you're always going to have it. Some cases can cause a permanent loss of hearing, however. So this is something, if you are losing anything that you have, and I say anytime you have a sudden change, loss of hearing, you should go see somebody right away. If the symptoms become chronic, then further testing might be appropriate, and there's many other tests that they can do. Okay, now we're going to go on to Meniere's disease, something else that you may have heard of. So Meniere's disease is a progressive inner ear disorder. Onset is usually between 40 to 60 years of age. The exact cause is unknown. The mechanism is thought to be a change in the fluid volume and or mixing of fluids in the inner ear. And so you have what's called endolymph, which is inside those semicircular canals, and perilymph, which is outside. There are different densities, and sometimes there can be an event that causes them to mix, and so this changes the input to the inner ear. The symptoms include recurrent attacks of fluctuating hearing, dizziness or vertigo, ear fullness, and tinnitus or ringing in the ears that lasts minutes to hours. So this is another one that's kind of the hours-long variety. It may be preceded by an aura, which is sort of a change in sort of visual sensation sometimes, or sometimes even smell, some kind of sensory disturbance. And then it can be followed by extreme fatigue and exhaustion. Now, between these attacks, oftentimes people are symptom-free. They actually feel great and they feel fine. But what happens is it's diagnosed again by history. So when someone comes in and they have this episodes of dizziness, they say, I had this, and then it went away after a week or so. And then I had another one a year later. So oftentimes they're coming in and saying, you know, I have this that keeps coming on and on. Then another way they can diagnose it is using serial audiograms or hearing tests. Because it is unfortunately a progressive disorder, and that hearing test will show a progressive loss of hearing, specifically in the lower frequencies. So this is different from the normal aging loss of hearing. When we lose our hearing as we age, we lose it in the higher frequencies. We can't hear higher pitched voices. With Meniere's disease, you lose it in the lower frequencies. So oftentimes that's conversational. So if you have a history of episodic dizziness, I get these episodes, and when I have it, my hearing isn't good, my ears are ringing, it's full, I feel terrible, and then it goes away. But I'm, noticing I'm having a hard time hearing over the years. Then you might want to get that checked out. And so typically to monitor you, they'll suggest you come in, I think annually, to get a hearing test at least. Treatment includes conservative measures such as a reduced sodium diet, medications to relieve symptoms during an attack, and vestibular therapy to help imbalance between the attack and provide education and self-management. So for the 20 to 40% who don't respond to conservative measures, it can be treated with what's called an intratympanic gentamicin injection or surgery. And really what that is doing is it knocks out the function in the ear that's having the problem. So we have two peripheral systems. We have one on either side. And if this one keeps getting these attacks, that makes me feel horrible. And this has been going on for years. And when I'm in it, I can barely move. Sometimes they'll go, the gentamicin is actually an antibiotic that's ototoxic, meaning that it destroys the hair cells. And then they can do a surgery. So basically they take it out. So it does mean that you can have a permanent loss of hearing on that side. You will have a bit of imbalance because you will have what's called the unilateral hypofunction, meaning you'll only have one inner ear working. But for the people that have such severe symptoms, that's such a helpful thing because they feel miserable otherwise. So it can work. You do need time to recover from that type of treatment. So conservative measures can provide some relief for 60 to 80% of those effective, and gentamicin is over 80% effective, but again involves the risk of permanent hearing loss and imbalance. Okay. Next, we're going to discuss vestibular migraine, which is also known as migraine-associated vertigo. So this is a type of migraine that manifests with vestibular symptoms, not necessarily headache. So, of course, most people think of migraine as migraine headaches. Unfortunately, if you have a history of migraine headaches, you can be predisposed to it developing into a vestibular migraine. And you have dizziness and vestibular symptoms. So you may not even have a headache while you're having the dizziness. This onset is usually between 20 to 50 years of age. So the symptoms can be described as lightheadedness, swimmy headedness, dizziness or vertigo, motion intolerance, so kind of like being car sick, difficulty in busy or moving environments, such as a grocery store, hearing changes, ear pressure, photophobia, which is a sensitivity to light, or phonosensitivity, sensitivity to noises or loud noises, and sometimes confusion, lasting seconds to minutes to hours to days. So this is something that's pretty encompassing. It can be similar to Meniere's and can be difficult to diagnose between Meniere's and vestibular migraine because they are both considered episodic. Usually people will come in and say, I have this, it lasts for a while, and then it goes away. So it can seem similar. The treatment is vestibular rehabilitation, which is essential to reduce symptoms and improve function. Also, identifying and managing lifestyle and dietary triggers is important. If any of you have a migraine headache, you may know that there are a lot of environmental, dietary, functional stress triggers that can lead to a migraine. Same thing for vestibular migraine. So regular exercise, stress management, techniques to lower the sympathetic nervous system's fight or flight response, because that is part of what's happening. Medications can include beta blockers, tricyclic antidepressants, calcium channel blockers, and certain anticonvulsants. The prognosis is that most people can find a way to live a normal life, and there's no permanent damage. Okay? Yes.
What does vestibular rehabilitation mean?
Yeah, good question. We're going to talk a little bit more about that later. Yeah. Go ahead.
Someone recently told me she had visual migraines. Does that relate to this or is that different?
That can be different. Yeah, that can be different. That could be kind of a crossover between migraine manifesting as a headache and vestibular. So, yeah, migraine can encompass a lot of different things. Yeah. Okay, so now let's talk about aging and dizziness. So, although there are natural physical changes that occur as we age, dizziness and falls are not just a part of getting older. So I want to dispel that because this has kind of been how things have been treated in the past. You go to the doctor, say you're dizzy. Oh, sorry, you're getting old. You got to live with it. Well, don't put up with that because it is not necessarily a normal part of aging. So again, all these things that I'm telling you, honestly, and vestibular therapy are things that have been delineated in just the past 30 years. So again, I graduated 30 some years ago, and there was no vestibular therapy, and a lot of these disorders were not even something that was diagnosed. So this is a lot of kind of newer research. And so that is why you may go to some physicians who aren't really familiar with it. So keeping probing, asking for assistance and referrals is helpful. So the vestibular system does undergo age-related cellular changes. So our sensory cells do degenerate, as do neurons that transmit sensory information to the brain. When this happens, then our brain has to rely more heavily on the two other major systems, so our vision and our somatosensory system. Then if these are affected, for example, cataracts, macular degeneration, joint replacements, arthritis. Sound familiar? So now you may have something that affects your vision, something that affects your somatosensory system, and something that affects your vestibular system. So can you see how it sort of becomes this cascade of impairments, and then maybe there's a tipping point. And then when your brain has trouble managing all that and figuring out what to do with it, that's when something can really become blown out of proportion. But you can do therapy to help all these areas. So dizziness, lightheadedness, and vertigo can be due to a variety of causes. So there are the vestibular disorders that I mentioned. There are also central nervous system disorders, such as stroke. So that is the other thing to realize, is that if you are having a sudden issue like this, again, don't hesitate. Go ahead, get some treatment and assessment. Go to the emergency room if it's really bad. Now, if it is a peripheral disorder, they may do tests such as a CAT scan, MRIs, things like that, and say, you don't have anything. That's a good thing. It's not going to tell you what's happening with your vertigo, but it's good because they are ruling out things like a stroke, tumors, etc. Then you should ask for a referral to a specialist to evaluate further. They may give you medication in the emergency room to help with your symptoms, and that's good right in that moment. But that does not help in the long run. And in fact, the most common medication they give, which is called meclizine, is intended or should be used just in the short term to help calm your symptoms. But meclizine is a vestibular suppressant. So if you use it your entire life on a regular basis, it's actually not helping the original problem, and it can cause more issues. Cardiovascular issues can also cause dizziness. So if you have low or high blood pressure or cardiac dysfunction, you can feel dizzy or off balance. Pulmonary issues such as COPD, emphysema. Low blood sugar can certainly make you dizzy, lightheaded. Infection. hyperventilation associated with anxiety, medications. If you've ever looked at your medication side effects, many of them include dizziness as a side effect. Dehydration, one of the most common causes of dizziness, passing out, lightheadedness. Don't underestimate it. Definitely stay hydrated. And then inadequate or poor diet. Does anyone have any questions right now? Okay, so here's on to hopefully answer some other questions. So who do you see? So again, your primary care physician is a great first stop. Let them know. And even if they're not doing a lot right away, oftentimes it's an ongoing story. They might say, because again, some of these other things that can cause dizziness that I mentioned, they may be temporary things. You can get dehydrated and then you get hydrated and you feel fine. So it may be a one-time thing. But if this is something that is recurring and something that is affecting your function, then continue to let your doctor know. ENT, so that's the ear, nose, and throat doctor, or a neuro-otologist, which is a specialized type of ENT. A physical therapist. Again, not all physical therapists are trained in vestibular therapy, so some of them and more physical therapists are becoming familiar, at least with the basics, and may be able to treat and assess BPPV, but some of the more complex disorders really should be seen by a specialist who has special training in vestibular therapy. A neurologist. So sometimes you may see a neurologist because you may have a concurrent neurological disorder. And I have several patients who are under the care of a neurologist and a neuro-otologist and an optometrist and the physical therapist to address all these things together. Yes?
What about cranial sacral work? Is that in here?
So that is not a component of vestibular therapy. Some people may find it helpful because some of these issues, so there is a form of dizziness that's also coming from the neck called cervicogenic dizziness. And so it may have something to do that. And then honestly, I'm only vaguely familiar with craniosacral therapy, but it is something that you might find helpful, but is not going to treat, address, or diagnose an inner ear disorder. Okay, so the diagnosis of a vestibular disorder comes from history. What we say is 90% of my diagnosis or your specialist diagnosis is going to come from your history. So there is on that back table a paper which has some questions. And if you're going to see a doctor, if you can fill those out first, or a vestibular therapist, that will give them lots of information and a heads up to help focus their evaluation for you. Clinical examination. So when we examine someone, we are looking at how they walk, stand, move. There's specific balance testing we do to isolate those different sensory inputs. And then there's specific testing, again, for BPPV, putting someone's head in certain positions. There's also specific testing that I do of the eye movement and function. Some vestibular tests that can be done include, as I mentioned, the VNG. That stands for video nystagmography. So that is where it's a test that's done where some goggles, again, are put on your eyes. You won't be able to see, but there's small cameras which reflect the eye movement. And it's a computerized program that measures eye movement. So we know the norm of what should happen with eye movement depending on where our head is and with different tests, and it measures that. Few other types I have up there called the VHIT, which is another kind of specialized computerized test, a VEMP, which is one that measures muscle responses as a reflex coordinating with the vestibular system. Rotary chair, this is actually a chair you sit in that spins you around and it measures your eye movement in response, because as you spin, that's going to move the fluid in your inner ears and the eyes will move in response to that. So again, checking how fast they move, the direction, comparing it to the norms and what we expect. Most of those other ones, and there's actually a few other tests, the other or more specific in-depth tests, those are, again, only going to be offered really at UCSF or Stanford.
Oh.
Yes, go ahead.
My doctor ordered a sleep study because he said
that sleep apnea could actually contribute to vertigo, even though I did not have it, but that was a possible contributor to vertigo.
Um, so that's a good. So are you wondering if
So I
it
was
is
just
or?
wondering if
Yeah, yeah.
a sleep disorder could contribute.
Yeah.
to-
You know, at this point in time, I don't know of specific testing which associates a sleep disorder directly. Certainly, your sleep will affect the function of your brain and your whole body. So it certainly can be. But I have no doubt that there's going to be other studies in the future that look at that and look at relationships. Yes.
The specialized tests that only are given at UCSF and Stanford, is that when an ENT or specialist cannot figure out what's going on?
Correct. Yes. Yeah. Yeah. So that's when more work needs to be done to look at it. So, for instance, and I might be something that I might recommend. So, if I have a patient who comes in the door, and sometimes I have someone who has seen their primary care doctor, sometimes they've seen an ENT, sometimes they're just coming to me because they found me and they have these symptoms. I can do some different testing to see if there's an inner ear problem. And that's what this is looking at, the peripheral and central vestibular system. If I can do that and find some things to treat, we go ahead and treat. We don't have to wait for those. So definitely don't have to wait to have those tests done. And if someone responds, and there's many people I've seen, they may not even need a VNG. But if they're not responding to the vestibular therapy, or in the testing that I do, I find something that just sparks a suggestion of something else, then I may recommend to their doctor to send them for VNG testing. You could get the VNG testing done, so your primary care physician could send you for a VNG test. And locally, again, here, I do know of just Audiology Associates in Santa Rosa does VNG testing. They could get that done, and then you could have that test result taken with you when you go to an ENT. And there is an ENT group in Santa Rosa on 4th Street, Marin Health ENT, and two physicians there specifically, Dr. Cedars and Dr. Aubin Pulio, who I worked with quite a bit and have a lot of specialized training in vestibular disorders. So, yeah, they can also order this testing, and if it's beyond their realm, then they may send you to UCSF or Stanford. Did you have a question?
I was gonna say that I had gone to Santa Rosa
Uh-huh.
Audiology,
Okay.
had that.
Oh, you did? So you've had the VNG test. What'd you think? It doesn't feel great, right?
But from there, then I was sent to the therapy.
Yes, yes. Yeah. Yeah. So, yeah, go ahead.
No physical therapists in town who do the Epley maneuver and more advanced treatments.
Are you talking about in Sebastopol, Julie?
Santa Rosa area.
Yeah. Well, so I used to work at North Santa Rosa Physical Therapy on Dutton Avenue, and my colleague there, who's still there, Marianne Potts, and she did the lecture on fall prevention, I think? Fall risk last week. So she treats vestibular disorders.
There's one in
Um,
Windsor.
One in Windsor?
I remember.
Okay, yeah. There's also a group called Peltz and Associates
That's one.
in Santa Rosa. So yeah, Peltz, P-E-L-T-Z. So again, there's various levels of training. So again, I would just be, you can ask specifically how much training they have. So the one training that I did at Emory University, which is kind of considered or has been considered the gold standard for vestibular competency. And so if somebody says they went to Emory University, or Herdman, Susan Herdman is a physical therapist who pioneered this. If they had that training, then that's a good place to start. And I'm going to refer you to, there's a site called VITA, and I have some handouts back there that have the information for VITA on it, VEDA, which is also the Vestibular Disorders Association. You can go on their site, you can punch in your zip code, and it will pull up a list of providers who are specialists in vestibular treatment and assessment.
Are you gonna mention later, so
Mm-hmm.
the types of therapy that they do?
So, what is
Look
good
at that.
segue? Good thing you had that question. So, what is vestibular therapy? So, vestibular therapy is provided by a physical therapist with advanced training. As I mentioned, the current gold standard is through Emory University. Although there's many other vestibular competency training courses that are coming out right now, and there's not a specific specialty board certification within physical therapy yet, but we're working on that. The evaluation will include a comprehensive assessment of the peripheral, that's the inner ear, and central vestibular system, that's the brain, using infrared or Frenzel goggles is sometimes what they're called. Also the ocular motor system, which is the eyes and vision function. Neurological and musculoskeletal systems, so I may check someone's strength, their reflexes, and other specific sort of reflexes which can tell me if they have a central or peripheral neurological deficit. Balance testing and walking. Then from there, we provide education and exercises. And education is probably the first thing I do with anybody who's coming in, and then something that's ongoing. Because this is something, and you're getting the education right now that I give to a lot of the patients, that is sort of mysterious. It's not something that you can see on an MRI or a CT or traditional imaging. And because it's something that can present very differently in different people. But again, you saw there are different disorders which require different treatment. A lot of this is educating my patient in terms of what's happening to them, what they're doing, and why they're doing it. Because I've had many people come in and say, oh, I've had this, I've had the Epley's done and it didn't work. And I can show them either they were doing it incorrectly or whoever had done it incorrectly, or it didn't work because they don't have BPPV, or I have someone come in and they've got a combination of things. So a lot of that education is important because the things that we're going to ask you to do don't feel great. They can tend to make the dizziness worse for a moment. But what we say is the thing that makes you most dizzy can be the thing that heals you. So that is the tough thing, is some of them we're asking you to create symptoms and make yourself dizzy. Who wants to feel that, right? But if I can explain to you why you're doing it and you understand, then it can help you tolerate it, go through it, and do it at the right intensity, so the right dosage, we call it, so that it helps you get better without creating severe symptoms. So VOR times 1 is a classic exercise. So that is stands for the vestibulo-ocular reflex. So what this is if I'm turning my head side to side, but I'm walking forward, and when we're walking and even when we're driving, I'm moving side to side. I'm not just going straight and still unless I was a robot, which I'm not. So in order to keep myself steady, as my body moves one way, my eyes have to move opposite at the same velocity, and that is called a one-to-one gain. And if one inner ear isn't working and I can't tell how far I'm moving or what direction, then my eye may not be able to stay steady on whatever I'm looking at, and I get a little shift of it. That can cause my world to actually move around. So what I'm looking at might actually jump around. That's called oscillopsia. Or I may be walking around and it looks like everything's kind of moving. So that's where that reflex isn't working. So when you get a peripheral hypofunction, which is can be occurring from vestibular neuritis or vestibular labyrinthitis or Meniere's, those are things that affect the peripheral ear on one side. That's your inner gyroscope. So imagine you have one side that's off, because kind of on your plane, you're going, you can't stay straight and level. So you can train the other side input. So you train the brain to compensate using the other side. So the movement and the therapy consists of exercises which we call compensation. So that might be training the other side. Adaptation. So that might be if I had an injury to that one inner ear, but now it's kind of healing. I have to train the brain to use that again. It's kind of like if you have an injury to your knee and you're limping and you can't use it for a while, you can't put weight on it. But now that's healed up. The swelling's gone down, the ligaments are healed, it's good. But a lot of times you don't automatically go back to walking normally because your body sort of forgets how to use it. And you have to relearn, and you go to hopefully a physical therapist who teaches you how to bend that knee, move it, get your strength back. Same thing for that healing inner ear. So that's adaptation. And the third component is something called habituation. So when I am walking around and say I have a vestibular migraine and, everything just makes me feel awful. So everyone's felt some vestibular symptoms at some point. Say if you've had car sickness or you've been on a boat and you get seasickness, right? And so that makes you feel awful, and the environment can make you feel terrible because it's hard to fixate on it. So you start to avoid it, and you start to avoid these kind of environments. But the more you do, the more your body and brain get sensitized to it. So if you're around that again, it's like, I don't like that, it's making me nauseous. So habituation involves actually exposing your brain and your system to those type of things that make you feel awful, so that instead of your brain going, oh my gosh, I'm gonna get nauseous and throw up if I go to the grocery store, not a good place to throw up, that I can say, okay, I can deal with this, and I can do some breathing and bring my sensory nervous system, the fight or flight system down, and hey, I feel better. And if you've ever had seasickness, and I did being on a boat one time, the reason you get it is because that mismatch between the vestibular system and your vision. Again, if you're in the cabin of the boat, you can't tell which way you are moving. But if you come on up to the boat deck and you can see a horizon, then you can see relative to the horizon which way you're moving. It gives your brain some other input. But for that moment, you might be going, oh my gosh. If you can actually breathe through it, you can calm it down. And luckily for me, I was able to calm it down without having to go stand at the edge of the boat there. But it's difficult. So those are how vestibular therapy works to help improve symptoms, help the system adapt and adjust, and help you feel better and function. So sensory OPK videos, which is listed as also called optokinetic videos, those are videos which have stripes that move. And there's actually, there's a lot of research done, again, to determine what happens with eye movement and eye perception and our vision related to our inner ear. And so there's actually specific, so some people have a disorder called mal de débarquement, which is where you're on a boat or a cruise ship and you get off and you feel like you're rocking all the time. So there's this mismatch, this something that went wrong in the inner ear. And they have studies which show that exposure to these stripes that move can help reset the brain. So it's all very interesting, high-level stuff that we're continuing to do research on. Did you have a question, Jill?
Could you say a couple sentences about orthostatic hypotension?
Yeah, so orthostatic hypotension, which we have a handout on in the back, is something that we wanted to bring up because it is also a very common reason for getting lightheaded, dizzy, and potentially passing out or falling. So that is not an inner ear disorder. That has to do with your cardiovascular system. And so what that is it's natural. So when we are laying down or resting, our heart doesn't have to pump as hard to move our blood around our body. Our blood vessels can relax. When I come sit up, gravity is going to pull the blood down to my feet, away from my head, and for that moment, I'm going to feel lightheaded. And all of us have felt that at some point if you get up too quickly, especially if you've been sick and in bed for days and you sit up and you go, whoa. Now, that can be exacerbated if you are taking blood pressure medications, if you are sick, again, for an extended period, or any other number of things that may affect your mobility, your cardiovascular function, etc. And so when you have that, you can help yourself, and a lot of people do, by kind of taking a moment and resting when you sit up, and then taking your time when you stand up. But if it's something that continues to happen, there's actually testing that's done in physical therapy, and doctors can do it, where we actually measure the blood pressure supine laying down and then standing for 1 minute and standing for 3 minutes. And there's a certain threshold that delineates that you do have orthostatic hypotension, and then that can be addressed. Does that sound good? Okay. So the goals of vestibular therapy are to improve dizziness, use of the eyes, tolerance to positions and movement, the ability to walk, reducing fall risk, and provide education. So some resources and reference are, again, the VITA, Vestibular Disorders Association, and I think, again, there's some handouts in the back that you can grab, which will have that listed, and the American Physical Therapy Association, and this site, which is called choosept.com. I think there's also a section there where you can find a vestibular therapist, and also just learn more about how physical therapists can help you. Thank you for coming today. I hope that this has helped answer some questions, and I hope everybody stays safe. Any other questions right now?
So, the little hairs in your ear,
Mm-hmm.
they lose their ability,
As we age,
yeah.
yeah, we can just lose some of them. So we have.
Is there any way to get that back? Does that lead to hearing loss?
That's a very good question. I don't know there's a way to regenerate the hair cells in the inner ear. It doesn't necessarily itself lead to hearing loss because the structures of hearing are something a little different, but because that whole area is kind of intimately related, it can be concurrent, but yeah. But again, the other things that can destroy it are certain antibiotics. So that's that gentamicin that I mentioned. So I have had some patients who have received heavy dose antibiotics for other things in the past, and so the result is they've had a complete hearing loss. Now, was it important that they got it? Yes, because it probably saved their life. Maybe they were having encephalitis or something, so they needed to have that. So with anything, sometimes there's those effects. Yeah.
So it's like,
Yeah. No, go ahead.
so can your hearing ever come back?
If you are having a sudden onset infection related to vestibular neuritis or labyrinthitis, or you're having some hearing, progressive hearing impairment related to Meniere's, so something that's affecting the inner ear, you can have a loss that can partially come back depending on how much something is affected. So it depends on the history, is what I would say. Beyond that, that's probably getting out of the realm of my expertise, and I may be totally wrong with what I'm saying with that. So those are probably better questions for an audiologist. If you have hearing loss or hearing impairment, I would totally encourage you to get a hearing test. Don't wait. It can tell a lot of different things. And the other thing is, hearing aids can be beneficial to help with your balance and your walking, because again, it's a sensory input. And so if anyone walked in here and you kind of close one ear down, it's a little disorienting. And so getting something that helps your hearing helps give you more sensory input. And there's all kinds of new hearing aids out there. There's very specific ones. It does take time to adapt to using them. But if you go to somebody and get them adjusted to you, it can help your balance. Mm-hmm. Did you have a question?
So if someone does have a permanent vestibular loss,
Mm-hmm.
can they learn to use the other two systems? Like
Correct.
vision and-
Yes, exactly. So that's that component of compensation that we do in vestibular therapy is if you have a loss on one side, usually it's focusing on using the other side and also sharpening the visual input and the somatosensory. So somatosensory includes pressure sensors or touch sensors. So this can be where if you've got peripheral neuropathy and you have numbness, that affects your somatosensory system. So whatever you can do to, I think you asked about just kind of managing your blood pressure. Bottom line with all of this, whatever you can do to manage any of your chronic health conditions, diabetes, high blood pressure, etc., helps all of this, helps the health of your whole body. Yeah, did you have a question?
Yes, it's probably way too general, but
No problem.
what are some nutritional components for taking care of?
The inner ear. Yeah, no, that's a great question. So the one thing I'll mention, and this is actually related to fall prevention, is I think there are studies relating vitamin D, right? Vitamin D to fall risk reduction. So definitely there's a relationship with that. And then there can be a relationship there's if you have some component of vestibular migraine and or Meniere's, because Meniere's can be related to your salt intake because it depends on the density of the fluid in your body and the pressure. Beyond that, it may be out of the realm of my expertise again, but certainly there are some specific nutritional approaches that can help. And there's actually a cookbook called The Dizzy Cook that I think it was a patient who wrote that. And it's more specifically for people that have vestibular migraine and how certain foods can exacerbate symptoms. So the Dizzy Cook. So again, Vita, that site Vita, has a lot of great information. You could probably ask all these questions or look that up in Vita and it'd probably have some information. There is a section, a paper back there on communicating with your doctor. Again, this is important, just like the things that I mentioned, is if you can be specific with your history, that's important. This is a Vita Dizziness and Balance Medical History Questionnaire. If you filled this out and took it with you to a provider, it can give them information. This is something else called, from Vita, called 10 Things You Didn't Know About the Balance or Vestibular System. Hopefully you know some of them now that you've come here. And a paper that says, how does the balance system work? One on orthostatic hypotension, and then just a couple other graphics called Steady As You Go and Feeling Dizzy 1-3. Okay. Thank you very much. Thanks for coming today. Have a great day.